How many people are we now?
10. Admit them in, right?
Do we start?
Wait, I'm just bringing them in now.
Okay. Good evening, everybody. I hope you I hope you can hear me. Please, if you can hear me, let's wave or do something. So,
Yes, you can hear Dr. Olo.
oh, thank you very much, Dr. Brown. So, we're welcome to today's clinical conference. And while we're waiting for other people to join, I want us to remember that the link for the attendance will be in the chat box so that we can attend to that in the course of the presentation. And okay, so the link is there already. So you can do justice to that as we continue with the presentation. And today we are looking into another branch of cardiology. May not be something we are very familiar with. That is geriatric cardiology, and we're looking at a very important topic that has a very big implication on cardiovascular disease and cardiovascular health generally. And the reason why this is important is over the last few decades, the aging population has been increasing, and according to different studies, in the next few years, by 2034, it's even been said that by 2034, the aged population will be more than the younger population. That means people 65-year-old and above will be more than the young people. So it is very important to know the challenges associated with this age group and how it affects different cardiovascular condition. And I termed it a deadly combination because it is like a vicious cycle. So cardiovascular disease increases the rate, the prevalence of frailty, and frailty in turn also worsens the prognosis, the outcome, and also increase the incidence and prevalence of cardiovascular disease. And also, we'll see a lot of other things that they have in common. And what are the main objective of today's presentation? The two broad objective is we'll be able to understand at the end of the presentation what we mean by frailty and the association it has with cardiovascular condition. And we will also at the end be able to know how to assess, how to measure frailty, and then the intervention, various intervention that we can do to help our patients so that we'll be able to reduce its effects. And so, like I said, the aging population is increasing, and as we know that cardiovascular disease is the leading cause of death, both mortality and mortality in this group of patients. And we also know from our traditional non-modifiable risk factor that age is a risk factor for cardiovascular disease. And that means as the population of the aged people 65 years and above is increasing, that means the incidence of cardiovascular disease is also going to be on the high. And when we're able to identify patients that are frail, then we'll be able to improve the outcome of our patients with different cardiovascular disease condition. So how do we define frailty? And this is one of the challenged with this topic because for now there is no consensus about the definition. So different tools, different studies come down, they've been able to come down with different definition of frailty. But what is common to all the definition is there's a state of decline in physiologic reserve and resilience to different stressors. And also there is increased vulnerability to both internal and external stressor due to dysregulation or abnormality of various physiological systems. So, but as defined by Freud in a study in 2001, defined frailty as a state of vulnerability that is caused by dysregulation among various physiological systems, leading to impaired resilience and subsequent failure of hemostatic mechanism to cope with internal and external stressor. So the main thing, like I said, is because of dysfunction or dysregulation in various systems, as we will see the hormonal system, metabolic system, stress-related system, stress response system, the individual lost that physiological ability to be able to resist both internal and external stressor, whether it is infection, whether it is trauma, whether it is a stroke, and the ability for the system to go back to equilibrium is lost, and the system now becomes vulnerable to different type of stressor. And it is something that we need to know that it is not a disease state. And it is also not a disability, though as the state of frailty progresses, the patients eventually become disabled and now become dependent with difficulty to be able to perform activities of daily living. But someone can be frail without having a disability, and somebody can have disability without frailty. For example, a young person that has a road traffic injury with maybe a spinal cord disease has a disability, but it is not frail by the time we look at the tools used to identify patients with frailty. And the definition also take into consideration, we have a phenotypic syndrome, whereas we are dealing with much of physical attributes that you can use to judge a patient. And we also have another one that we call the frailty index that takes into consideration other domain, because frailty is not just physical. It could be cognitive, it could be social, it could be nutritional. So, but this definition that I've given is talking about the phenotypic, the physical type. And like I said, frailty can stand on its own. Like I said, this is not a disease state, different from disability, but it can coexist with comorbidity and can also lead patients to become, to get into the disability stage. So, and also patients or people with multiple medical condition have high risk of becoming frail, and also patients with disability easily become frail, and frailty can also be a cause of disability. So it comes together, but at the same time, like I said, frailty is a distinct entity on his own. And if we're looking at the phenotypic frailty, like I said, defined by Freud in a study done in 2001, we have 5 criteria that we will use to decide whether an individual is frail or not. And starting from the earliest criteria to to the last one. The first one is exhaustion. So when you ask patients question about whether the patient gets tired easily, how much effort that is required for patient to do his or her daily activity. Then weakness, we'll talk more about how to assess this as we progress in the discussion. Exhaustion, weakness, that is measured by decreased grip strength. Whether the patient is slow, when we're looking in detail into this, we will see what we mean by someone becoming slow. But overall, when someone cannot walk, it's taking more than 6 seconds to walk a distance of 15 feet or about 4 to 5 meters. We'll look at this later in detail. Then low physical activity and unintentional weight loss. That is weight loss more than 5% in the last 1 year. And when you look at these 5 criteria, if there is none, then the patient is very robust. That means the patient is very fit. If you have 1 to 2 of the criteria, then that is called pre-frail. When you have 3 or more, then the patient is frail. That means from frail to severe frailty, which is when you have all the 5 criteria present. And we can see the continuum, like I said. So patient goes from being robust when there is none of the 5 criteria, then to pre-frail state, which is when you have 1 or 2 of the 5 criteria, which can be the pre-frail. Then you now go to the frailty state, which is between 3 and 5. Then you have early frail, like 3 criteria, late frail, patient with 4, and by the time the patient has all the criteria, the patient is severely frail. And at that point, the patient, like I said, is totally dependent and is not able to perform activity of daily living, so which is disability. And also along the continuum, up to a certain extent, with intervention, it is reversible. But by the time the patients get to the late frail and the severe frail states, then it might be almost impossible for the patient to be able to go back to the early stage. And this is also just showing us a natural history of frailty. And when we were talking about the definition, we're talking about the ability of an individual system to be able to resist or rebound when there is stressor. So when there is stressor, if we look from the beginning of the graph, the curve is the ability of the system to be able to rebound after there is a stress response. So you will see the curve, the system was depressed and the patient was able to come back to equilibrium within the shortest possible time, looking at the radius of the curve. But as you go down on that continuum, then it takes longer for the body to be able to recover, and you will discover that gradually the patient lost that ability to be able to come back to equilibrium until that clinical frailty threshold is crossed and the patient totally lost the ability, that physiological reserve and resilience, and now becomes so vulnerable to any stressor, whether from internal or external stressor. And the second definition, because the first one, like I said, majorly take into consideration of physical attributes. You will see that out of the 5 criteria mentioned, there was nothing that talks about cognitive function. There's nothing that talks about the social aspect of the patient. There is nothing that takes into consideration that, because if you will assess those 5 criteria, the patient has to be active. You can't do that for a debilitated patient. You can't test the strength. You can't test the ability of the patient to walk because the slowness is there, exhaustion is there, and other things. So But the frailty index now takes into consideration other domain, cognitive, functional, social, psychosocial, and is able to take all this, including comorbidities, into consideration. And in frailty index, you can assess up to about 90 different things, but the least that should be assessed is 30. And now frailty index is now generated to assess the level of frailty in the patient. Apart from the fact that this can address different domains, other advantage that it has that this can follow up the patient, and the patient can be assessed from time to time, because frailty is a dynamic state. It's not that once a patient is in this state, the patient is always there. Like I said, the patient can progress down the ladder, and if interventions are quickly done, the patient can also get better. And frailty index is able to track the patient along that continuum better than the phenotypic criteria that we talked about. So then, why are we so interested in knowing about frailty? And is this something that is very important? So we now see that, like I said, that the aging population is increasing, and so also is the prevalence of frailty in this group of patients. And depending on the tool, the instrument that is used to assess the degree of frailty, it could be as low as 4% and as high as almost 60% in the patient 65-year-old and above. And even the patients with pre-frail stage, also almost about 50%. And in patients with cardiovascular disease, the prevalence is greater than 40%, as we will see as we go on. And like I mentioned earlier, that by 2034, studies have shown that adults 65 years old and above will outnumber youths by 2034, and cardiovascular patients are especially vulnerable in this state. And then, why are we saying that there is this bidirectional association, that it is a double jeopardy? Like I said, the prevalence of frailty in patients with established CVD is more than patients without in the general population. As we will see, about 30% of patients with coronary artery disease have frailty. Patients with valvular heart disease, generally more than 65% of them are frail. And in patients with aortic stenosis, about 74% of them, you can see that prevalence. And patients with established cardiovascular disease, they are predisposed to developing frailty faster than patients without cardiovascular disease, and also the onset is faster and earlier in patients with cardiovascular disease. And frail patients have more major adverse cardiovascular events, even when the degree or the severity of their cardiovascular disease is even less. So it worsens the outcome, it worsens the prognosis, both based on medical therapy and even intervention-wise in patients with coronary artery disease, whether they are doing PCI or whether they are doing CABG, patients with valvular disease, whether they are doing transcatheter or they are doing open surgery, frailty worsens the outcome in this group of patients. And that is why it is important to assess patients so that you will know the degree of frailty and you will know how to intervene accordingly. And especially in patients with heart failure, overall, about 40 to 80% of patients with heart failure are very frail. And it is worse in patients with heart failure with preserved ejection fraction. As we know that Heart failure with preserved ejection fraction primarily affects elderly patients. And in this group of patients, up to 90% of them range between early frailty to severe frailty. And with those in those with reduced ejection fraction, about 30 to 60% of them are frail. And frailty increase all-cause death and hospitalization up to 2 times in patients with heart failure. That means when you have 2 heart failure patients, one that is not frail and one that is frail, that means the frailty of the patient, the outcome of patients with heart failure with frailty is worse, even when symptomatically the patient with heart failure with frailty, the symptom is not even as worse as the other one. But the fact that the patient is frail now puts him at a worse prognosis and outcome when you compare with the other patients. And in the absence of other traditional cardiovascular risk factor, frailty is a more potent and important prognostic indicator, like I said earlier. And it is worse in male, though women are more frail in terms of number, but the outcome in frail men is worse when compared to women. And it has also been found that heart failure patients with frailty are likely to be denied access to guideline-directed medical therapy. They are likely to receive the optimal dose because of side effects, which is common in this age group. And sometimes they may even be denied access to some intervention. Like we know, when we look at the guideline for ICD, for CRTD, you will see that they put it there for patients that are likely not to survive more than 1 year, that they should not be given. And this is one of the cases where you look at the frailty score and you can say, oh, this patient is less likely to live above 1 year. So this patient now will not have the ICD or the CRTD or other intervention. And this is why we need to assess frailty in this group of patients to actually know which of these patients is frail, because as we will see as we proceed, it is not something that you can just look at the patient by the bedside and say, oh, because the patient looks like this patient is likely to be frail. And in patients with valvular disease, like I discussed earlier, about 65% of them are old and are frail. And specifically, I talked about aortic stenosis, where about 75% of patients with aortic stenosis have severe frailty. And like I said, irrespective of the choosing approach, whether transcatheter or surgical procedure, frailty worsens the outcome of this patient. However, some studies have shown that for patients with severe aortic stenosis, moderate and severe mitral stenosis, that treatment, as in transcatheter repair or even surgical repair, was found to improve their level of frailty. So current data now underscore the importance of appropriate treatment in valvular heart disease, because we know the transcatheter approach was designed for patients that could not do the open surgery. So it's been found that it somewhat reverse frailty in patients with severe aortic stenosis and severe mitral stenosis. So now, this is an area where more studies need to be done to be able to determine how frailty and the outcome of valvular heart disease patients. And in patients with coronary artery disease, we know frail patients have reduced mobility, which is also a risk factor for development or progression of coronary artery disease. Coronary artery disease patients, inversely, they have pain, they have angina and other symptoms which also limit their physical activity, say, and leading to that vicious cycle. And like other conditions, frail patients are likely going to have worse quality of life and worse outcome. But this has a lot of controversy because in most of the studies done for patients with coronary artery disease, whether those having PCI or those going for surgery, the age group that is 75 years and above, they are grossly underrepresented. And even in the studies where you have them, most of the patients that were recruited cannot be said to be in the frail and severe frailty class. So it's difficult now to establish that relationship between frailty and coronary artery disease. But in this study done by Ratkovich et al., they look at their patients 70 years and above that were referred for coronary angiogram, and they looked at the 12 months all-cause mortality in this group of patients. And they found that patients with frailty have worse and higher 12 months mortality than other patients that are not frail. And the tool they use there is the clinical frailty scale, which we'll talk about later, which is easy to use. Even a nurse and other health workers can be trained to use this. And after they have corrected and adjusted for other factors, they found that frailty is a very strong prognostic indicator, and it is associated with higher 12-month mortality in the patient. And they found that it is similar to the Gray-Screen score that we use in patients with coronary artery disease that are doing coronary angiogram. So it compares side by side with Gray's risk score. And so this is something that we can replicate here to also look at the effect of frailty on the outcome of our patient coming for coronary angiogram. And this is just showing that patients with frailty, that they are the one in red, they have worse outcome compared to vulnerable and the robust patients. And these are other studies showing the prevalence of coronary artery disease in other study when we look at the not frail patients, pre-frail and frail patients. You can see in cardiovascular study about 38% prevalence of coronary artery disease compared to 17% in patients that are not frail, down to, you can see the large effect, and it depends on the tool used, because if you use the phenotypic tool, the prevalence might be small, but by the time that you combine other domain in the frailty index score, then you have very high prevalence states. And gait speed, which I talked about, that's the slowness, we'll look at that later, also has been found that it can predict the outcome and morbidity and mortality in patients undergoing surgery, even when you compare it to the Society of Thoracic Surgery score, which is used as a prognostic indicator. Gait speed, I mean the time that it takes for someone to walk 15 feet, that is 4 to 5 meters, because ideally for elderly patients to be able to walk that distance at the speed of 1 meter per seconds, then it is allowed, can do 0.8 meter per second. But once it is less than that, then the gait speed is slowing down, and that is a predictor of major morbidity or mortality after cardiac surgery. And also, I talked about the grip strength, which measures strength, is also an indicator of case fatality rates from MI, stroke, patient with cancer, patient with fall, and we'll see that patients with the lowest hand grip stress and grip strength, they are the one that are with highest case fatality rate across the different conditions from MI to pneumonia to fracture. So we showing that frailty is an important prognostic factor. And now we want to look at the biology or the pathophysiology of frailty and cardiovascular disease. And this is the other way where you have that bi-directional relationship, because we found that the underlying biology is similar to both of them, and this includes chronic inflammation, immune activation, presence of comorbidities, and other metabolic dysregulation. So the effect of chronic inflammation has been found to be a major driver of both cardiovascular disease and frailty. And then in them, it has been found that chronic inflammation inhibits growth factor expression and increase catabolism, which leads to sarcopenia, which is loss of muscle strength and muscle bulk, and also frailty. So, and that same chronic inflammation has also been found to be the driver of atherosclerosis and other factor that is responsible for development of cardiovascular disease. And in this group of patients, both in patients with frailty and cardiovascular disease, the marker of chronic inflammation, interleukin-6, tumor necrosis factor alpha, have been found to be very elevated, including C-reactive protein. Other cellular changes and include mitochondrial dysfunction, DNA repair dysfunction. All these have been found to lead to poor energy supply of the muscle, leading to weakness, exhaustion, and those factors has also been found to be related to remodeling in the cardiac muscle, related to endothelial dysfunction, related to decreased nitric oxide activity, which are the underlying pathophysiology that is responsible for development of coronary artery disease. And in elderly patients, it has also been found that metabolic dysregulation, which include low testosterone, metabolic syndrome, increased steroid activities, all of this also plays an important role in development of frailty and cardiovascular disease. So we can see that they have a lot of underlying pathophysiology which is common, and this now is also compounded by the presence of comorbidity, diabetes, kidney disease, high blood pressure, and other environmental factors. Like I said, that frailty does not only affect the physical state alone, you can also have the psychosocial, the mental, and the nutrition. And another thing is also poor nutrition has also been found to be also common to both patients in this group. And like I said, so it's a combination of both the environment and the genetics. And the driver, like I said, mitochondrial dysfunction, poor DNA repair, obesity, oxidative stress, insulin resistance, all this drives the abnormality in the different system, the stress response system, musculoskeletal system, metabolic dysfunction, leading to both cardiovascular disease and physical frailty syndrome. And like we have mentioned that these two also affect each other. Cardiovascular disease increase the risk of frailty, and frailty increase the incidence of cardiovascular disease and also worsens the outcome of cardiovascular condition. What of patients without CVD? It has also been found that frailty increases the incidence of future cardiovascular events in patients without cardiovascular disease. So it is not only patients with cardiovascular. So elderly patients with that cardiovascular disease need to be assessed to know whether they have frailty or not, because once they are frail, they have very high risk of developing future cardiovascular events. And these are different studies that's shown that frailty and even pre-frailty increase the development of cardiovascular disease in patients without cardiovascular disease. If you look at this second one, it said pre-frailty and frailty were associated with 1.6-fold to 2.6-fold increased risk of fatal CVD. That is in patients without CVD. So you can see why it is important to assess this in our patients 65-year-old and above. Then frailties too has also been found to be associated with subclinical cardiovascular disease. In patients with frailty, that is in people in population without obvious cardiovascular disease, they've been found that they have carotid stenosis in more than 75%. You can see ECG and echo features, left atrial dilatation, left ventricular hypertrophy, diastolic dysfunction, autonomic dysfunction, and increased pulmonary artery pressure in group of patients that they have not even presented, but when they were assessed to be frail and ECG was done for them, carotid Doppler ultrasound was done, they found that they have some subclinical cardiovascular disease. So now the question is can frailty now be classified as one of the cardiovascular risk factor that should be assessed going forward? Those are one of the things to be considered as we go forward. Now the question is, how do we measure frailty in our patients? And I talked about an eyeball assessment because that has also been discussed. This was a study done in New Zealand that, okay, as a doctor, I should be able to look at the patient and say, oh, this patient is likely going to be frail. And that was put to test, that using a quick clinical assessment, that is by looking at the patient and just asking one or two questions, versus using a validated frailty assessment tool. So this was done in New Zealand. 2 consultants and 1 senior registrar was asked independently to just look at the patient, ask 1 or 2 questions, and determine whether this patient is frail or not. Then the same patients were now assessed using validated frailty assessment. And the result was that none of the 3 clinicians showed satisfactory similarity to the validated frailty assessment tool. The one that was used here was the reported Edmonton Frail Scale, that is REFS. And they found that none of them agreed. And the conclusion was that a quick foot of the bed clinical assessment is not a reliable way to determine frailty, because by the time you put your elderly patient on the bed, everybody is going to look sick. Everybody is going to look frail. So just by mere looking at them, you cannot assess their frailty now. Then that now takes us to the question that how do we now assess them? And like I said, there are so many tools. And the question is, for now, there has been no validated tool that can say is superior to others. So use the one you have. Use the one you are conversant with. And the commonest, the two most cited are the fried phenotype that we talked about and the deficits frail index proposed by Rockwood and colleague, that those are the two commonest one, and this is taking us back to the fried frailty criteria I talked about, using exhaustion, weakness, slowness, low physical activity, and unintentional weight loss. And I talked about the limitation of these because other domain was not assessed, cannot be assessed, and this can also not be used for debilitated patient because you cannot test the muscle strength, you cannot test uh, gait speed, and you find it difficult to assess their level of physical activity, and that is what is rare. So the Fried phenotype is a 5-point assessment. It can easily be performed in the clinic, but like I said, the limitation only assess physical domain. You cannot use it to longitudinally track changes in patient frailty status, and the patient that are functionally disabled, its use is limited. But in Rockwood frailty scale that I talked about, that a lot of domain and a lot of factor is assessed, and the minimum is 30. It is time consuming. You may not be able to do that quickly in a clinic setting, but the advantage is it assesses patients in all domain and can be used to track patients along the scale. Then there's clinical frailty scale. This is a 9-point scale that can be quickly used by the bedside. And this was what was used for the study I talked about that assess quick assessment against a validated scale. And it's easy. From 1 to 9, you can assess whether patient is very fit, well, managing, whether patient is vulnerable, then from mildly frail to terminally ill, by just asking the patient or the caregiver or the family the question and assess, and you can easily say, okay, this patient is okay, this patient is severely frail, this patient is terminally ill, when you ask question in each category. Then there's also the frail scale. The frail scale just go by the word frail. By the word frail, you ask question about fatigue, about resistance, whether you have difficulty climbing a stair, ambulation, do you have difficulty walking one block, whether there are comorbidity, cancer, heart failure, then whether loss of weight, and you can give the patient 1 for yes, 0 for no, and score the patient. Anyone with 3 to 5 is frail. Patient prefer 1 to 2, and 0, the patient is robust. The patient is very fit. And we have the essential toolkits, which we'll talk about later. We have the gait speed, and the essential toolkit is specifically designed for patients with valvular heart disease going for intervention, but it has also been tested in patients with coronary artery disease going for both PCI and CABG, and it has been found to predict their outcome. And it contains, you want to check whether the patient is anemic, you want to check the albumin level, whether the patient has hypoalbuminemia, then you want to assess their cognitive function using the Binet score, and you want to test their muscle strength using the chair rise test, which I will show you. Then I talk about gait speed. I will show us that later, and hand grip test. So for the essential frailty tool test for our iPhone user, there's an application in the iPhone called the frailty tool. That's, you just need to just put in the factor. I talked about anemia, hypoalbuminemia. Then the other 3, you can assess the Mini-Mental score by just asking 3 questions. You tell the patient those 3 things, you distract the patient, and you ask the patient to recall or repeat those words. If the patient is able to do that, then you score the number the patient is able to do. We'll talk about the chair rise test, and you just put those things in the in the application and the result of your hemoglobin and the albumin level, and you'll be able to get your score. So assessing the hand grip test, like I said, you want to see the muscle strength, because when we're talking about the biology, one important factor is sarcopenia, which is the loss of muscle bulk and muscle strength. So one of the ways is to measure hand grip test using the dynamometer. So what you want to do is for the patient to sit or stand, the arm at 90 degree, and hold the dynamometer as strong as possible. And it's going to measure the hand grip test. And you do that for both hands. You do 3 times, and you take the highest reading and you document. And for men, it is less than 30 kilogram, and for women, it's less than. So it is abnormal when it is less than 30 kilogram for men and less than 20 kilogram for women. Then there's a 30-second chair stand test, and what you want to do is look for a chair, preferably a seat without an armrest, and you ask the patient to cross his hand against his shoulder, and you want the patient to stand up and sit, and you want to know the number of time the patient can do that within 30 seconds. So the higher the number, the better the strength of the patient. And so the cutoff is there for each age group, but generally less than 14 for 60 to 64, or less than 12. So you want the patient to sit up, get up, sit down, sit up, stand up, sit down, stand up, sit down within 30 seconds, and you count the number and you record the number of time the patient is able to do that within 30 seconds. Then the gait speed. Like I said, what you want to do is to mark a walkway about 6 meters. The first 2 meters is the acceleration zone, and the last 2 meters is the deceleration zone. The area you want to time is the 4 meters in between the distance. And like I said, a fit elderly individual should be able to do this within 1 minute, or let's say 0.8. Should be able to do 0.4, should be able to do 1 meter per second, or 0.8, not less than 0.8 meter per second. That means within 5 seconds, you should be able to walk the 4 meters. And this is an illustration that is just showing by the age and gender the walking speed. And walking speed is now being proposed to be the 6th vital sign in elderly patients, that as we are measuring the blood pressure, the pulse rate, the respiratory rate, we should also assess the walking speed of the patient. And like I said, once someone is taking more than 6 seconds to walk that 4 meters, then we know there is problem, because the walking speed has gone down. And from a study done by Studenski in 2011, the lower the gait speed, the worse the median survival year. And so if you can just increase the walk speed by the gait speed by 0.1 meter per second, we can reduce 1 year mortality by as high as 10%. So from here, exercise is one of the major interventions that we need to encourage the elderly patient to do, because exercise has been found to be able to reverse the continuum on that scale. And so if an elderly patient starts exercise very early, and you can improve their gait speed. And now the good thing is that irrespective of the way you can increase the gait speed, even by the use of assistance, whether by walker or whatever, anything that helps to improve the gait speed improve their survival and also reduce their mortality. So it is not just about walking alone. Even the patient can walk faster with the aid of a walking stick, a walker. You should do it, and that improve their lifestyle. And so, what are the intervention? Like I said, it is not only for cardiology. So geriatrician has to be involved, cardiologist, physical therapy, because like I said, exercise has been proven to improve the level of frailty by moving the patient back from frailty to either pre-frail or even to a fit level. So it is it's involved the nurse, the social worker, the cardiologist, and everybody has to come into play because a lot of things need to be done. Dietitian, because you have to improve their nutrition, increase protein intake. The use of vitamin D has been found to improve muscle strength in this group of patients. Then we need to do their medication review by reducing the amount of medication they are. And the American Geriatric Society have the different criteria, the BS criteria that can be a guide to removing inappropriate medication for this group of patients. Then lifestyle modification, everything that improves the traditional cardiovascular risk factor also improve the level of frailty in elderly patients, and we also have to manage the other comorbidities. So this just shows everything that I've talked about. So the risk factor, exercise has been proven, and it remains the only proven strategy for preventing and reversing frailty. So the key is early engagement, good diet, like I said, management of social problem, mental health problem. This is where the social worker, the psychiatrist, everybody comes into play. Then we have to manage all the comorbidities, diabetes. Here it has been found that tight glycemic control increase adverse effects. So the target by ADA is to target A1C that is less than 7.5%. You don't want a very tight control in this group of patients. About the blood pressure, there's still controversy about what is the target, what is the best. You have different things from sprint studies and other studies, but try and control blood pressure. How low? Still a point to be discussed and for further study. And for cardiovascular management, like I said, percutaneous aortic valve and mitral valve repair has been shown to reduce frailty. For those of them that have acute coronary syndrome, short-term use of dual antiplatelets has been found to be helpful in them because long use increase the risk of bleeding. And for those with heart failure, GDMT must be used. And SGLT2 inhibitor and GLP-1 agonist has been found to improve the level of frailty and mitigate frailty risk in patients with heart failure. So this patient must be on dapagliflozin as shown by different paradigm. A lot of studies have shown. So your management of heart failure in this group of patients should include the use of SGLT2 inhibitor. And as we know, this group of patients are also the ones that are at risk of developing non-valvular atrial fibrillation. So the use of the oral anticoagulant is very, very useful and is important and has been found to be more effective with lower bleeding risk compared to warfarin. And apixaban has been found to be better than rivaroxaban in this group of patients. And now, for patients that have been on warfarin, switching them to novel oral anticoagulants has been found to increase their bleeding risk. So in this group of patients, when you are seeing them, they have atrial fibrillation, you want to place them on anticoagulant, it is better to just start them on the NOAC, preferably apixaban. And you can do that at a relatively lower dose of 2.5 BD as against using rivaroxaban or placing them on warfarin. Because if you give them warfarin and you want to switch from warfarin to either rivaroxaban, apixaban, or dabigatran, then studies have shown that there's increased bleeding risk in this group of patients. And so simply doing the American Heart Association Life Simple 7 can reduce the risk of frailty. That means you manage the patient's lipid profile, control the blood pressure, stop smoking, manage blood sugar, good and balanced diets, exercise, all has been found to improve their level of frailty. And this is just putting together everything that I've mentioned about managing frailty in this group of patients. So what are the future things that need to be done? One, like I said, there's lack of consensus on the definition. So work still need to be done to be able to determine which of the tool is the best. Early screening, intervention. So when is early? Is it at the age of 60? Is it at 50? Is it at 55? Work still need to be done on that. Then can we routinely assess frailty in cardiovascular care? Can it be the sixth vital sign, especially talking about maybe the frailty phenotypic criteria or assessing gait speed or muscle strength? Then personalized intervention. So this question I want to ask, does integrating frailty assessment into existing cardiovascular model, does it improve outcome? Like I said, what is the optimal timing, method, and target population to assess frailty in adult with cardiovascular disease? Should cardiovascular therapy be tailored based on individual frailty status? Do I want to pattern my treatment based on the individual status, or we want to use one treatment that fits all, irrespective of the frailty status? Then can guideline-directed cardiovascular medical therapy, can it prevent or reverse frailty? Then do frailty intervention lead to improvement in cardiovascular outcome? These are things that we can work on so that we can answer the question. So to conclude, frailty is not a disease state. Frailty is not a reason to withhold care, but it is a tool that helps to facilitate patient-centered care and minimize risk from therapy and from cardiovascular disease. And the benefit of routine frailty screening has been shown in high-risk clinical contexts, whether oncology, surgery. So definitely it should have benefits in our patients with cardiovascular disease. Thank you very much. And I think I've not made you frail and old with all my English. Thank you very much for listening. And I can take questions and comments from distinguished people on the call. Thank you very much. So Dr. Mark, I think Dr. Mark is there. I've rested. So if there is any contribution, any comment, any question. So, and I believe we have filled the link, the attendance link in the chat box. So any comments? Any comments? I hope I've not made us old in the last 50 minutes or so, because I know it's not something that we are familiar with. It is not heart failure. It is not atrial fibrillation. So, but it's something that will affect those conditions if not well assessed and taken care of. So question, comments, it is either I've confused everybody or I've done a very bad job.
Nobody gone. Everybody stay, right?
So I think people are not making comments. Can I still give maybe 2 minutes for any comment on the floor before we call it a day? So next week, we'll circulate the next topic that will be discussed. But as time goes by, we'll be looking at all these other domains. Okay, I can see a question from the chat box that can the same method be used to measure frailty in children? My answer will be, so far, frailty is associated with aging. So we don't expect, at least for now, a child to be frail, going by the definition and the criteria that is used. So looking at frailty is in terms of aging. Though, like I mentioned, that a young person can be frail without comorbidity, but if you look in that context and we assess most of the domain, most of the criteria, at least in the phenotypic frail criteria, we'll see that a young person or a child will be able to pass that test in terms of gait speed, physical strength, exhaustion, fatigue, and so. So for now, okay, you said, what of sickle cell children? Can we say they are frail? No, we may say they have multi-morbidity and maybe disability, but they are not frail in that term. Because like I said, frailty is not in terms of the frail in the English version and looking at someone weak. You have to look into all those domains before you can conclude that a patient is weak. And like I said, it's more in the context of aging and in elderly patients. So thank you, Dr. Kolaoli, for those questions. And I think those are some points that needs to be taken into consideration in doing future studies and maybe trying some of those tools in younger patients. And when I was talking about the time to intervene or time to start screening, the question is, when is the ideal time? When is the time to come in? When do you say is the early time? Is it at the age of 50? Is it at 40? Is it at 30? Is it at 60? Or do we need to wait until the patient is in that elderly age group, the 65 and above, before you start using those tools? So thank you for that question, and thank you for staying till the end of the presentation with us. And like I said, we'll meet again next week, Thursday, for another clinical conference, and we get to know. And we get to circulate the topic early next week. Thank you for joining us, and good night. Thank you very much.